This is going to be the last recorded lecture on myasthenia gravis in the cluster of autoimmune diseases for exam number 2. So what is myasthenia gravis? Myasthenia gravis is an autoimmune disease that affects the neuromuscular junction, so we call it a neuromuscular disease, where a patient will experience significant muscle weakness and fatigue of skeletal muscle. So we're talking about muscles that affect eye movement, muscles that affect phonation, muscles that affect swallowing, muscles that affect breathing, and muscles that affect the movement of our arms and legs. So what happens in this particular disease process is there's a destruction of the acetylcholine receptor sites. So there's enough neurotransmitter acetylcholine, but there's not enough receptor sites to be able to bind and produce a muscle contraction. So we have muscle weakness that's exacerbated when the muscle is used. And in this particular disease process, this particular autoimmune disease, there's no cure available. So we can control it with certain medication. So I want you to go back into the recesses of your days of pathophysiology and biology and remember that every time that we want to enjoy a muscle movement, when an impulse is generated, the nerve will release acetylcholine. And that acetylcholine, which is a neurotransmitter, it's going to bind at the acetylcholine receptor site. So in biology, we call that lock and key theory. So they bind together. And as a result, a voluntary skeletal muscle contraction can occur. So after that process occurs, then there's an enzyme, acetylcholine, that breaks down the acetylcholine and recycles it. That's the normal process. But in myasthenia gravis, there are autoantibodies that are formed against those receptor sites. So they're destroyed. So we have a decreased number of receptor sites to bind with the neurotransmitter acetylcholine. So as a result, this is going to lead to muscle weakness and the impairment of muscle use and muscle movement. So what are we going to do for these patients? We're going to use anti-acetylcholine esterase medications. It's an important tool that we use to treat these patients so that the acetylcholine is not broken down as rapidly, so that there's more acetylcholine available at the neuromuscular junction. So when a receptor site opens up, there is a neurotransmitter that is available at that time to bind at that junction. So that's how pretty much it works in a nutshell. So one of the things about myasthenia gravis, researchers and scientists don't know what the cause of myasthenia gravis is, but we know that the thymus gland is usually large in this particular population of patients. So when we're born, we have a very large thymus gland, and that thymus gland produces lymphocytes, T lymphocytes, to help with the immune system, with the immune process. And the T lymphocytes are white blood cells. So in children, we all know about the immune system of children. So it's very large in children, but as we get older, when we hit puberty, the thymus gland should begin shrinking. And as we get older and older, that thymus gland should be very small. But we know that in myasthenia gravis patients, that thymus gland is large, okay? And so the thymus gland sits behind the sternum and is located between the lungs. And so the theory there is that the thymus gland is responsible for producing antibodies that attack the receptor sites at the neuromuscular junction and leads to myasthenia gravis. So what are you going to see in these patients? How are they going to present to you? Well, they're going to present with muscle weakness. And so we're always concerned, obviously, about the respiratory system because these patients can have respiratory compromise. You can see that they'll have impaired respiratory effort, they'll have shortness of breath, dyspnea, tachypnea. They'll be using accessory muscles, and you know, in an adult, we have severe respiratory distress when we see the use of accessory muscles. They can be hypoxic, it can lead to respiratory failure, and it can lead to intubation. So we also need to assess our patients' energy levels. We want them to pace themselves. We need to look at their performance status, their energy levels, their abilities to perform their activities of daily living. The best time of the day for these patients to get the majority of their activities done is in the morning, but again, we want them to pace themselves. We need to assess vision. Vision is really important. One of the first signs that patients will develop that have myasthenia gravis is diplopia, which you'll remember is double vision. But they'll have visual disturbances, they can have diplopia, they can have blurred vision, they can have ptosis, and that's where they'll have an impairment in their extraocular eye movement. And some people call that a lazy eye, where their eye is not completely opened. You want to also be concerned about nutrition in patients that may have the muscles that we use for swallowing affected. So they might not be able to swallow. They might be choking or coughing when they're drinking or eating, which increases their risk for aspiration, which increases their risk for pneumonia. So you want to assess your patients for any nutritional concerns, which includes, stable weight. What does their lab values look like? What does their albumin and total protein look like in a patient that is malnourished, for example? So speech can also be affected. So, of course, there's significant muscle use that's used when we speak. We can have muscle weakness and fatigue in that area. And so they may have a difficult time speaking. Their voice might fade. And they may have difficult just continuing conversation, a flowing conversation. And you may have difficulty hearing them as time goes on just because of that weakness. And of course, we always need to assess for infection because infection is a stressor that can lead to an exacerbation of myasthenia gravis and lead to a crisis. So think about these patients having weakness. They may have eyelid drooping. They may also have a mask-like facial appearance where they look sleepy, they're expressionless, their face muscles are weak. And just remember that you need to always assess them for their ability to swallow before you're giving them food or medications or anything like that, because the last thing that we need is aspiration in this type of a patient, or any patient for that matter. So how are we going to diagnose them? This is always a challenging topic because what we're doing with the Tensilon challenge is we're trying to determine whether the patient has myasthenia gravis or whether they are in a cholinergic crisis. So one is not enough acetylcholine and the other one is too much, and we're going to talk specifically about that. So as the nurse, one of the things that you need to always have available to you is emergency equipment and emergency medication, because these patients can improve or they can deteriorate depending on what's actually happening with them. So Tensilon, or the generic name for Tensilon, is edrophonium. And so what does it do? It prevents the breakdown of acetylcholine, which is, I told you earlier, is a neurotransmitter that our nerves release to stimulate a muscle contraction. So it's used for diagnostic purposes. So what is the outcome? What are we looking for? So in myasthenia gravis, once we give Tensilon, if the patient is being diagnosed with myasthenia gravis, you're going to see improvement in their status almost immediately, because what you've done is you've given them some additional acetylcholine that's going to be available at the neuromuscular junction, that's going to be able to bind at that receptor site, and is going to result in a effective muscle contraction. So it's a good thing for patients who have myasthenia gravis. Not such a good thing when the patient has a cholinergic crisis. In a cholinergic crisis, there's too much of that neurotransmitter acetylcholine at the neuromuscular junction, and the patient will, if you give them edrophonium, they're going to have too much medication on board in the system, and you're going to see deterioration. So what are the signs of a cholinergic crisis? So a cholinergic crisis occurs when there's too much anticholinesterase drug that has been administered. So this condition can cause your patient to become kind of very sick. So you'll see that they have nausea and vomiting, they'll have abdominal pain, they'll have an increase in bronchial secretions, they'll experience blurred vision, they'll have some sweating and some hypotension. So when we have a crisis, we're going to stop the anticholinesterase medication, and we're going to give the reversal agent, which is atropine. So atropine is the emergency medication to reverse or improve a cholinergic crisis. So atropine, we're going to give it at 0.4 to 0.6 milligrams IV, IM, or sub-Q. So know the difference between myasthenia gravis and cholinergic crisis. And I do have another slide. Hopefully it'll become clear as time goes on here. So EMG, what is EMG? It's electromyography, which examines the electrical activity between the patient's brain and their muscles. So in this particular patient, you're going to see poor electrical conductivity. It's going to be slowed. You'll see that response between the brain and the muscle is going to be decreased or slowed down. We're going to use a chest x-ray especially in patients that have had an exacerbation, that are very weak. We're always worried about aspiration. We're looking for pneumonia because we know that pneumonia can lead to aspiration pneumonia can lead to sepsis, and we can go down that rabbit hole. The CT, they'll get a CT of the chest to evaluate for that thymus gland. Is that thymus gland enlarged? And sometimes most patients elect to have a thymectomy, which is a removal of the thymus gland, because as an adult, it's non-functional, and we believe that thymus gland is responsible for the production of those autoantibodies. So what we're looking for also is we can draw blood for acetylcholine receptor antibodies, and in a patient with myasthenia gravis, you'll see that these antibodies are positive. So here's the next slide is about the Tensilon challenge. So this is where we give edrophonium, an anticholinesterase agent, and it's going to be used to confirm the diagnosis of myasthenia gravis and differentiate it from crisis events. So what happens here? The edrophonium inhibits the breakdown of acetylcholine, thus increasing the amount of acetylcholine activity within the neuromuscular junction. So if you have myasthenia gravis, that's a good thing, because I'm adding more neurotransmitter that's going to be available at that neuromuscular junction. But if I'm in crisis, that's a bad thing, because I just gave more medication. So that can be not a good thing. All right. So what are our priority interventions? Well, emergency equipment and medication should be at the bedside when you have these patients with a deterioration of their neuromuscular status, because we're worried, of course, about respiratory insufficiency and failure. These are going to be of high priority, so you want to make sure that you have things available to support the respiratory system, your crash cart, your cardiopulmonary monitoring, things to intubate with in the event that you should need to do so. And let's see. Let's talk about medication. One of the medications, which is an anticholinesterase, which is pyridostigmine, which is something that we're going to give to patients with myasthenia gravis, because we want to inhibit the breakdown of acetylcholine, because in those patients we want them to have more neuromuscular acetylcholine at that junction, so that they can have an improvement in muscle contraction. But we don't want them to have too much of it. So in a myasthenic crisis, you know, the patient can be thrown in crisis because of something that triggered it. So things like illnesses, upper respiratory infections, bacterial, viral, pregnancies, surgery, big stressors in their life that can lead to a crisis. And if we have a crisis, that can lead to respiratory insufficiency, respiratory failure, because the weakness of those muscles impact breathing and they impact swallowing. So we have to be, you know, we're always on the lookout for not enough medication and too much medication. So of course, like any good nurse, you're going to monitor vital signs. You're going to balance activity with rest. You want to reduce the patient's fatigue. So another thing that you want to do is make sure that we teach the patient to ensure that they have sufficient amounts of drug on board. So we want them to have therapeutic drug levels of medication. And also we want to give them things that are, for example, foods that are easy to chew. You're not going to give them a steak and things like that, because they're going to be using those muscles, they're going to get weaker, and they're going to have difficulty swallowing, and it's going to increase their risk for aspiration. And so in the treatment plan, we can use things like plasmapheresis, again, plasmapheresis to reduce some of those side effects. And usually their immune system is boosted with several doses of IVIG, which boosts their immune system. We can also give things like prednisone, which is the most commonly used steroid in the treatment of myasthenia gravis, but we know what happens when we give steroids, and we know that we need to know the side effects of those steroids, and we need to know that of course steroid use decreases their immune response, and we want to give them enough medication to suppress things, but we don't want to give them so much medication that their immune system is non-functional. Okay, so what drugs are being used in myasthenia gravis? Pyridostigmine is an anticholinesterase medication. We can also use corticosteroids like prednisone and immunosuppressants like Imuran, Cellcept, and cyclosporin. Those are important. So anticholinesterase, pyridostigmine, again, blocks or prevents the breakdown of the neurotransmitter acetylcholine and enhances nerve impulse transmission. And so at that neuromuscular junction, the nerve is going to effectively innervate that muscle and produce a voluntary muscle contraction. So the dose must be tailored, and then the nurse needs to know the side effects of this drug, because this drug is a fine balancing act, okay? Also, when you're looking at side effects, don't forget to look at the drug-to-drug interactions, because you know you have a patient who has a neuromuscular problem, and there are drug-to-drug interactions for these patients when we're using things that are going to further suppress muscle contraction activity, like anesthetics, for example, tranquilizers, opioids, muscle relaxers. Those, to me, they're just like, that's just like a contraindication. But there are other medications like antidysrhythmics, diuretics, and some thyroid medications that also are a drug-to-drug interaction. So let's talk a little bit about the treatment modalities that are available for these patients. We already talked about pyrostigmine, and prednisone, and some of the immune modulators that are available. But also we need to think about surgical intervention. A lot of these patients end up with removal of that large thymus gland that is thought to lead to myasthenia gravis, and plasmapheresis. And you need to know about plasmapheresis. So plasmapheresis to me is a little bit like dialysis. You're removing those antibody antigen complex through a filter, just like you are in dialysis. And there are, it's not innocuous. There are certain complications that can happen. You have to, when you're using plasmapheresis, you have to look at the risk-benefit ratio associated with that particular type of treatment, because these patients can have, an infection. They're going to have a central venous catheter to be able to have plasmapheresis, so that in and of itself creates a risk for infection. They can have clotting issues. They can have, obviously, allergic reactions. And also, it can disrupt some of their electrolytes. And the most common electrolyte that's disrupted is calcium. And so calcium can, lead to things like numbness and tingling in your fingers and your toes. It can also lead to abdominal cramping. It can also lead to seizures. So make sure that you look up, plasmapheresis and IVIG, and know what you would look for as the nurse with that particular treatment modality. So myasthenia gravis complications. So let's talk about myasthenia crisis. That means that you don't have enough acetylcholine, which is the neurotransmitter, available at the neuromuscular junction. So there's not enough there. There's not enough neurotransmitter that's going to be seated on whatever receptors are available. So it's going to lead to severe muscle weakness, possibly respiratory failure. So the causes, maybe you don't have enough anticholinesterase medication, pyrostigmine, for example. Perhaps there's something that caused an exacerbation, like an infection, like some kind of a stressor, maybe a surgical procedure. So medication will need to be adjusted when these patients have an acute illness, or they have a planned surgery, or there's some kind of stressor that could lead to crisis in these patients. Now, the opposite of that is a cholinergic crisis, okay, where there's too much acetylcholine present at that neuromuscular junction and not enough neurotransmitter is being recycled. So we have too much acetylcholine, which can lead to respiratory situations as well. So they'll have you might see bronchospasms, you might see a lot of bronchial secretions, wheezing, bradycardia, hypotension, pupillary constriction, an increase in what I already told you here, salivation, mucus production, bronchial secretions, tears, sweating. You'll have an increase in GI motility, everything speeding up, nausea, vomiting, diarrhea, bladder incontinence, and severe muscle weakness. So know the difference between myasthenia gravis crisis and cholinergic crisis. One is too much and one is too little. So some of the nursing diagnoses that are associated with myasthenia gravis is definitely ineffective breathing pattern related to muscle weakness due to myasthenia gravis, as evidenced by 1, 2, and 3. Impaired physical mobility related to whatever muscle group weakness we're talking about. Fatigue, risk for aspiration, knowledge deficit. Those are just to mention a few nursing diagnosis that can be associated with myasthenia gravis. So this is important, okay? So what are you going to do to teach your patients? How are you going to keep them safe? You're going to administer pyridostigmine 30 minutes to 1 hour prior to meals. We want there to be enough acetylcholine at that neuromuscular junction to be able to bind with the receptor site so the patient has enough strength to chew and to swallow safely without aspirating. So we're going to give them small meals versus large meals, soft foods versus foods that are difficult to chew, like steak, for example. If you are concerned, you can always collaborate with your speech language pathologist. Of course, you need to have an order for this. They're going to determine if the patient has a safe swallow, and they're going to recommend a certain type of diet and consistency. So if I were going to be giving a patient medication and I was concerned about their ability to swallow, I would be having that assessed in some form or fashion before I gave them medication or food or anything else. Okay, you want them, of course, to perform their activities in the morning hours when they have the greatest muscular strength, but you also want to make sure that you are pacing them. You don't want to try to do everything at once. They're always at risk for aspiration. They're at risk for falls because they usually have decreased strength, and they're at risk for respiratory failure as well. So one of the things that you're going to aim your teaching with these patients is the long-term trajectory of their disease. What do people need to know about living with this disease? You're going to teach them about their triggers, things that are going to worsen their symptoms. We know that there's going to be periods of remission and there's going to be periods of exacerbation, but we always want our patients to be in a state of homeostasis. That's what we're always trying to achieve, okay? So sometimes we have to make medication adjustments like I discussed before. So what are the triggers that precipitate an exacerbation or a flare? Things like I told you, stress, extreme changes in temperature, whether that's hot or whether that's cold, any trauma that they might sustain, hormonal changes also have to do with estrogen, menstruation, pregnancy, so forth and so on. Certain medications that are going to produce muscle weakness, and we talked a little bit about that. Surgery, infection is a huge stressor. It's really, and you want to, with your patients, you want to really stress the importance of a balance between rest and activity. Diet is important. Are they eating well-balanced, nutritious meals that are easy to chew, easy to swallow? What is their weight like? What do their lab values look like with regard to nutritional status? Teach your patients to schedule medications for maximal muscle strength effect at the time of activity, such as eating, or instruct on the proper administration of medications, adhering to the cautions of each drug and observing for the side effects. That's really important. And educate them on the signs and symptoms of either a myasthenic crisis or a cholinergic crisis, when to call the provider, when to present to the emergency room, and then what are their community resources that are available to them. And always encourage them to wear a Medi Alert bracelet so that if they are found down, the emergency medical team will know exactly what they can do for these patients. So that is going to conclude this series.